All right, let's talk about the wrist. It's an absolute marvel of biomechanics, right? But here's the crazy thing. When it fails, it's not random. It follows this predictable, almost scripted path from one tiny torn ligament all the way to a complete catastrophic collapse. And today, we're going to trace that exact cascade of failure, step by painful step.
Yeah, this really says it all. The wrist is a masterpiece, but it's also set up for this cascade of failure. Think about it. It can handle everything from delicate surgery to a heavyweight punch. But that incredible complexity, that's also its Achilles heel. One piece goes down and it sets off this devastating chain reaction. So you ready? Let's go find that first domino.
So where does this all start? Well, more often than not, it begins right here. Meet the unsung hero of wrist stability, the triangular fibrocartilage complex, or as we all call it, the TFCC. The easiest way to think about it, it's basically the meniscus of your wrist.
So what does this thing actually do? Well, the TFCC is this amazing load-bearing structure on the pinky side of your wrist. Its main job is to stabilize the joint between your two forearm bones, the radius and the ulna. This is what lets you twist and rotate your forearm, but it's also a heavy-duty shock absorber. I mean, every single time you do a push-up or, throw your hands out to catch yourself in a fall, that little TFCC is working overtime, taking a beating for you.
Now, here's the thing. The TFCC isn't just one single piece of tissue. It's actually a complex, right? It's made up of these 5 core components. And yeah, they all have a job to do, but if we really want to understand how things go wrong, we got to zero in on the 2 main players. We're talking about the central articular disc, that's the cushion, and the radial ulnar ligaments that basically lash your forearm bones together. These two, they're the real stars of the show.
Okay, so we know what it is, but what happens when this absolutely critical stabilizer fails? Well, like we said, it's not random. It tends to break down in 2 very distinct ways.
So you've basically got 2 types of TFCC injuries. On one side, you have class 1. These are the acute traumatic ones. Think of a sudden fall onto your outstretched hand. Bam, a tear. But then you have class 2 injuries, which are actually way more common. This is your classic wear and tear. It's a slow, degenerative process. On an MRI, you'll often see this as a little hole, a perforation, right in the middle of the disc. And this kind of chronic breakdown, it's often made a whole lot worse by a little quirk in your anatomy.
And that little quirk brings us to something that is absolutely key to understanding pretty much all wrist problems, ulnar variance. I know, it sounds super technical, but trust me, it's a simple idea. It's literally just about how long your 2 forearm bones are compared to each other, right at the wrist.
It breaks down into 3 simple categories. You've got neutral, where the ulna and radius are pretty much the same length. Then there's positive, where the ulna is a little bit longer. And finally, negative, where the ulna is a little shorter. That's it. But believe me, this tiny difference in length has absolutely massive implications for how your wrist handles stress.
And I'm not kidding about those consequences. If you have positive variance, that longer ulna bone is literally smashing into the TFCC in your carpal bones over and over again. This leads to those degenerative tears we talked about and a painful condition called ulnar impaction syndrome. On the flip side, if you have negative variance, that's strongly linked to something called Kienbach's disease, which is where the lunate bone actually dies from a lack of blood supply, all because the forces on the wrist are just off.
So, let's say you do tear your TFCC. The big question is, will it heal? Well, it completely depends on where it's torn. Remember how we said it's like the meniscus in your knee? It's the same deal here. The TFCC has a red zone with good blood supply and a white zone with almost none. The outer part, on the ulnar side, that's the red zone. It's vascular. It can heal pretty well. But the inner part, near the radius, that's the white zone. It's avascular, and a tear there, well, it's got a really tough time healing on its own.
Okay, so when a major stabilizer like the TFCC or another key player called the scapholunate ligament gives out, it's not just about pain, no. That's when the next domino falls. Carpal instability. And again, this isn't some random floppiness. The wrist starts to collapse in one of 2 very predictable but opposite patterns. We call them DISI and VISI.
All right, to get our heads around this, let's paint a picture. Imagine 2 of the most important carpal bones, the scaphoid and the lunate, are perched on a really steep hill. Now, just because of their shape and all the forces in your wrist, the scaphoid always wants to roll down the front of the hill. It wants to flex. And the lunate? It wants to do the exact opposite. It wants to roll down the back of the hill, into extension.
So you've got these 2 bones, wanting to roll in opposite directions. The only thing stopping them from just tumbling away is this little guy holding them together. Let's call him the scapholunate ligament man. He's our hero here.
So what happens when our hero gets injured? What happens when that ligament tears?
You guessed it, they go their separate ways. When that scapholunate ligament tears, the scaphoid does exactly what it wants to do. It rolls forward. And the lunate? With nothing holding it back, it rolls backward dorsally. This specific pattern of collapse has a name, dorsal intercalated segmental instability, or DISI for short. And you need to know this one because it's by far the most common type of wrist instability. The opposite, VISI, is way less common. That happens when the ligament on the other side of the lunate tears, which lets the scaphoid pull the lunate forward with it.
Now, this isn't just theory. These instabilities create really obvious warning signs that we can see on imaging, pointing us right to the problem. And this one is probably the most famous of all. When that scapholunate ligament goes, the two bones just drift apart, and on an X-ray, you see this gap open up. Anything more than 3 millimeters is a dead giveaway. It's called the Terry Thomas sign, named after an old British comedian who had this big famous gap in his front teeth. It's a classic sign that a DCIS collapse is underway. And a key detail here, it's the dorsal part of that ligament that really matters. It's the thickest, strongest part, and it's what's really preventing that collapse.
All right, let's zoom in on the scaphoid bone itself. First off, it's the most common carpal bone to fracture, period. But what makes it so tricky is its blood supply. It's completely backwards. The blood flows in at the far end and has to travel backwards to supply the near end. This is called retrograde flow, and it is a huge, huge problem. Why? Because if you snap the scaphoid right in the middle, at its waist, you can completely sever the blood supply to that whole first half of the bone.
And what happens when you cut off the blood supply? You get this, avascular necrosis, AVN. The bone tissue literally dies. Now, you might think the first sign on an X-ray would be the bone disappearing, but it's actually the opposite. The dead bone can't do its normal job of recycling minerals, so it actually looks whiter and denser than the living bone around it. We call that sclerosis. And when you see that, it's a major red flag.
Another really bad sign to look for after a scaphoid fracture is what's called a humpback deformity. This is exactly what it sounds like. The two broken pieces of the bone angle forward, creating this hump shape. You see it best on a side view X-ray, and it's a huge warning sign. It tells you the fracture is unstable, probably not going to heal right, and is heading straight for that DISI collapse pattern we keep talking about.
So, what happens if these things, the ligament tears, the unstable fractures, are missed or just left untreated? Well, the risk continues down that predictable path, right to the end game, total dislocation and crippling arthritis.
And even the dislocations happen in stages, from bad to worse. It all starts with that scapholunate gap we saw. As more ligaments tear, the entire carpus can dislocate around the lunate, which stays in place. That's a paralunate dislocation. If it's just ligaments that tear, we call it a lesser arc injury. But if a bone, like the scaphoid, fractures as part of the dislocation, that's a greater arc injury. But for both paths, the final stop is the same. The most severe injury, a full lunate dislocation, where the lunate itself gets popped right out of the joint like a watermelon seed.
And this is where it all ends. It doesn't matter if the journey started with a torn ligament or a broken scaphoid that never healed. The destination is a collapsed, arthritic wrist. We call it a SLAC wrist. That stands for scapholunate advanced collapse, if it came from the ligament injury. Or it's a SNAC wrist, scaphoid non-union advanced collapse, if it came from the fracture. Two different paths, same miserable outcome. The wrist's mechanics are completely shot, bones start migrating where they shouldn't, and you're left with painful, degenerative arthritis. So after walking through this entire domino effect, from one tiny ligament all the way to a completely wrecked wrist, it all boils down to one question, right? What's the one thing that could have stopped this whole chain reaction from ever starting? It's the integrity of those first few pieces, those initial stabilizers, the TFCC, the scapholunate ligament. Their stability, well, it turns out it's everything.